recorded.
All right, Chris, you there?
Yep, I just got back in. Apparently,
Okay.
didn't like me either. I just have to. The problem is I don't know that I can share my screen. There we go.
There we go. I just joined as a participant, and I'll just kind of talk through it if that's all right.
Sure. Let me just.
Yes. Again, sorry guys. I would have skipped drill, but the Army doesn't like that.
What screen would you like me to be on, Dr. McKay?
Just keep going. Next slide. Next slide. Next slide. Next slide. There we go. Keep going. Keep going. We're past this. Keep going. All right, we're right here. Okay. Is everyone back on board? I think so. You want to give it a second to see, or
There are a number of people on. I think you could probably just keep going.
just keep going. All right. So this is kind of a picture from where we were standing at top. The gentleman, again, he was middle-aged, kind of a little on the bigger side, but he was pinned in this corner. And the way he was sitting was that his left leg was extended out. His entire left lower extremity was mangled. It was like a Gumby. His right leg was smashed as well from his pelvis down, and it was wrapped underneath him. So his entire weight was sitting on his entire right lower extremity. It was folded underneath him. He was, unfortunately, one of those blades. You can go to the next slide. You can see those blades. Those are about 8-inch blades that were about an inch thick. That was stuck in his left flank, a good couple inches. So he was trapped in that corner. All of his weight his back was pinned against the corner, and that blade was stuck in his flank. And so all of his weight was pressing down on his right lower extremity. And then that blade, before it got stuck, filleted him open from his probably upper lumbar spine through his perineum. So that was just all folded open. So number of issues that we had to fight against. When we got on scene, the stat medevac had already initiated care. They had bilateral IV started, pain control, had him on oxygen. He's awake and talking, kind of in and out of it because of shock, obviously. Bleeding profusely, tourniquet in his left lower extremity. He's just kind of oozing blood from that where he was filleted open. You could see his spine from his lumbar spine all the way down through his perineum. So that's just to kind of set the picture. We had a very difficult time extricating him. Fire department was attempting to remove that entire cylinder from him. Ultimately, that was unsuccessful. We tried to use a plasma cutter. You can see some of the marks on the side. This was a less than quarter-inch metal here. We were just going to cut a piece out and essentially fold it out and pull the patient out. Once we started doing that, unfortunately, that cylinder slipped, pinned him against the wall. So now he couldn't breathe. He's starting to go unresponsive. So we ended up, that cylinder was connected to a boom crane, pulled it rapidly and pulled him out as a rapid extrication as best as we could. Unfortunately, at this point, we had exhausted all of our supplies of combat gauze, dressings. I was actually taking clay from the hopper and packing his wounds because we had nothing else to pack his wounds with. And then when I pulled him out, I had to grab him by the pelvis, and all of that muscle and soft tissue just came to the side. So it really just kind of exposed his spine. He was in pretty rough shape. But we were able to get him out and then subsequently transported him to St. E's, and you can go to the next slide just to give you an idea of kind of what we did. We did a lot while we were on scene. We had him connected to the cardiac monitor because the way he was positioned, and we'll talk about later, we were concerned for crush syndrome because he was essentially putting all of his weight on that right lower extremity, and he had no blood flow to that lower extremity. So we had him on the cardiac monitor. We had fluids going. We ended up giving him a ton of blood. So he had a mixed picture of hemorrhagic shock, potential crush syndrome. he was in pretty rough shape. So we did a lot. We had him on the cardiac monitor. We had him on high flow O2, bilateral IVs. Obviously, we packed his wounds as best as possible. Used every single dressing that we had on scene. We used all of our combat gauze. We were using clay. We had a tourniquet on his left lower extremity, and we didn't have great visual access to see. We just knew it, or that was put on before we had gotten there. At some point, he was bleeding from his lower extremity so much that they applied a tourniquet, but we couldn't really identify a source at that time. We gave him a ton of ketamine and fentanyl for pain control. And then we treated his crush syndrome, which we'll talk about later, with the sodium bicarb and calcium. We gave him 3 in total on scene, 3 liters of normal saline, 2 units of packed red blood cells, 3 units of whole blood. And right before we had to rapidly extricated him, we actually just had to essentially cut open his belly to get him off of that piece of metal. We didn't enter the perineum, but we cut through a lot of the soft tissue around on his stomach around that blade. So pretty invasive and technically challenging call, but we got quite a few things done. You can go ahead to the next slide. So that kind of brings into this Taka crush syndrome, right? I just kind of wanted to set this stage. These patients are going to be almost exclusively, these multi-system trauma patients. So it's a good idea to just have a picture in your mind as we're going through this. You can go to the next slide. Just some quick objectives. We're going to define crush syndrome. We're going to talk about compartment syndrome a little bit, and or crush injury, compartment syndrome, and crush syndrome. And we're going to talk about the pathology of crush injury, identify some of the causes of death from crush injury, some potential clinical manifestations, and then kind of the role of myoglobin and the other toxins involved in the diagnosis. So just real brief objectives. Go ahead to the next slide. We're going to talk about some therapeutic modalities. Oh, sorry, I didn't let you know. Yeah, the patient lived. I guess I really left you on the cliffhanger there. Patient lived. Ultimately went to St. E's, underwent countless surgeries, ended up getting transported down to West Penn Hospital for skin grafts months later. He's in extremely rough shape, but he lived. So back to the objectives, we're going to describe the care of the local injury and describe management of crush syndrome, and some of the controversial interventions. Next slide. So why does this matter, right? If I'm alluding that this isn't a very common thing, that we typically only see it in some of these very particular settings. But if you don't think about it, you will never see it, right? So why does this matter? Go ahead and click. Because we see potential patients for crush syndrome every single day. These are just some incidents from Pittsburgh within a few years. In Washington County, just kind of the southwest of Pittsburgh, we had a building collapse. Someone was trapped for greater than 8 hours. They had a refrigerator stuck on them. USAR team got called. It was a big thing. Next, we had this incident in 2021. Next, go ahead again. So again, we see building collapses, building fires, with structural collapse, vehicles into buildings, bridge collapses. Hit next. So these are all common incidents, right? We get dispatched to incidents like these all the time, and we don't see particularly the severely injured in these patients with every single incident, but the potential is there. So we have to have this in the back of our mind. Go ahead and hit next. Yeah, every time in Pittsburgh it stormed, we would get 1,800 trees into homes, and 1,700 of those never had any patient interaction, but every once in a while you'll get that tree that falls onto a home, and then the rubble lands on the patient and the patient's trapped. So it's something that you definitely will come across, and I'm sure here in Lancaster County that you've had incidences, or you can think of incidents that that patients may have been potential patients of this. All right, next slide. We see cars into buildings all the time. Next slide. Again, building collapses from fires. Next slide. Vehicles in the building. So this is really just demonstrating that we see potential for this type of injury pattern quite frequently, right? I mean, how many times in Lancaster County are you going to buildings or vehicles into buildings, or trees down? Next slide. Vehicle crashes. You get these. This was off 79 or 279. Patients who are trapped in vehicles for longer than 30 minutes. You get these big industrial vehicles that roll over onto another vehicle and become just an extrication nightmare. Next slide. So when we talk about these patients, right, there's a very particular course to this injury pattern, right? And historically, what we've seen, patients can survive entrapment for a really, really long time, right? We saw it. We see it almost every single day. Patients are trapped for 45 minutes, hour long. But then we see the extremes. We see them in earthquakes, in building collapses, 9/11, right? Patients are trapped for hours, for days, and they still can survive extended periods of time. But what we find is that these patients who ultimately succumb to these crush syndrome patterns is that shortly after they're extricated, they go into sudden cardiovascular collapse and then they die. And it's because of this cascade that we'll talk about in a little bit. And it is definitely one of those preventable disease states, right? So if we take early and aggressive care to the patient, we can prevent something like an adverse outcome from this syndrome. So this is where, when you're thinking of these patients that are trapped for prolonged periods of time, our natural instinct is to quickly remove them and just get them going. But we really need to sit there and think, could this patient be someone who's at risk for crush syndrome? And should we actually take our time and treat them before we extricate them? Next line. So when we talk about just some basic terminology, right? We have crush injury, crush syndrome, and then compartment syndrome. And they're three different identities, right? Crush injury is the injury itself. It's just a local injury tissue or to the tissue. That is where, the weight or whatever physical object has crushed your extremity. That act of injury is just a crush injury. Just because you have a crush injury doesn't mean that you have crush syndrome. Syndrome is a constellation of systemic manifestations like shock, rhabdomyolysis, and ultimately renal failure, which then leads to a couple other things that we'll talk about in a little bit. But the syndrome is the constellation of systemic manifestations that develop from the injury itself. And then compartment syndrome, when we talk about particularly the extremities, when you look at the extremities, they are separated into multiple compartments by fascia. And that fascia, in each compartment, there's blood vessels, nerves, muscle. And when that pressure builds up, it can actually cause vascular compromise. And that leads to compartment syndrome. So we will see compartment syndrome more commonly with orthopedic injuries, right? We worry about compartment syndrome when someone breaks a big bone and then we cast them, and a couple of days later they're coming back with severe intractable pain. They have numbness, paresthesias. We worry about the compartment syndrome. When we talk about the diagnosis of compartment syndrome, we classically have heard of the 5 Ps: pain, pallor, paresthesias, and those are the kind of classic findings of compartment syndrome. And you have to have a high risk or a high suspicion for that. Most often it is a clinical diagnosis, although we can measure the compartment pressures. It tends to be more of a clinical diagnosis. My buddy, actually, my old college roommate, ended up getting compartment syndrome. He was what do you call it when you're wakeboard, waterboarding or water skiing, and the rope got wrapped around his forearm and it pulled him forward, and essentially it tore every muscle in his forearm, and it swelled up pretty significantly. And then the next day he lost function of his hand. It was numb. He was having significant pain. So he had to go for emergent surgery and fasciotomy, and they opened up his compartment, released that pressure, and he ended up doing well. Next slide. So when we talk about the epidemiology, where do we see these crush syndrome patients, right? Historically and classically, we've seen them in times of war because of the true structural damage that we see from, particularly depending on the theme of the war, I guess, the unconventional warfare for the past 20 decades, we saw a lot of IEDs. But when you talk about if you're in Syria or that the Gaza Strip and you're just getting bombarded by missiles every day. World War II, all the bombings, we typically see this type of injury pattern in times of war, particularly in rubble and collapsed buildings. Same with earthquakes. Earthquakes are extremely high risk patient population for crush syndrome because they tend to be trapped for long periods of time. And then vehicle accidents. We don't commonly think of vehicle accidents, but this is in the continental U.S. in today's world, we can see this crush syndrome in vehicle accident patients. Next slide. And that's obviously the traumatic causes, right? And then we have these non-traumatic causes that physiologically cause the same type of syndrome, but we don't think about them as much because we tend to see this as solely a traumatic process, but we can see it in non-traumatic causes like extreme exertion. We see these marathon runners that ultimately get rhabdomyolysis from extreme exertion. They break down their muscles, they third space fluids, and then they lead into the same constellation of symptoms that we see with crush syndrome. Prolonged immobilization, like this guy kind of had or the guy from the case that I presented, he had kind of a multitude, right? He was he had a prolonged immobility, but he was trapped, and not necessarily trapped. But it wasn't like he had rubble on his leg. It was his own body weight on his leg for hours because he couldn't move because of being trapped from that cylinder with the blades. You can see it in hypothermia, and what we see is like a reperfusion injury when we warm them. And with arterial occlusion, we see that same type of pathology. If you have like a major arterial occlusion to the lower extremity and it's not treated aggressively and timely, we can see the same type of patterns. And I will tell you, we from a non-traumatic cause, a few years ago, my EMS service had, it was a classic patient, had a elderly patient passed out at the bottom of the stairs, didn't fall down the stairs, passed out, but the position that he landed on top of his leg, and he was too frail and weak to stand up. So he was there for days before someone found him. So whenever the crew had lifted him up, he arrested a few minutes later because of the same pathology. And that is something that they didn't think of crush syndrome just because, it's not common that you see crush syndrome outside of a traumatic cause, but it was that same idea where his entire body weight was on his lower extremity for days and he couldn't get up. So when they released him, and we'll talk about the physiology here in a minute, all those free radicals and toxins essentially flooded back into his system, ultimately leading to his cardiac arrest. Next slide. So when we talk about earthquakes are probably the more predominant. I don't want to say we don't have a lot of war because the current state of the world sucks right now, but earthquakes are a large proportion of the population that will see crush syndrome in, and we can see that in 11 to 14%. When we talk about the larger case series for these types of patients, we found that mortality was about 14%. And specific to earthquake patients, we found that crush syndrome is actually the second most common cause of death behind the trauma itself. And like I talked about earlier, this is something that is preventable with early and aggressive treatment at the point of injury. Next slide. So when was this first described? This was really first described during World War II in England, when London was just getting obliterated on a nightly basis by the Germans. You can see kind of what they had to deal with, just shells of buildings that were collapsed, and they would find these patients that were trapped for hours and days. Next slide. So these two doctors ended up reviewing cases that they pulled, and they published their findings in the British Medical Journal about this case series of 4 patients that they were ultimately pulled from the rubble and then developed this same constellation of symptoms within hours and days, and then succumbed to their injuries. So this is where it was first published. The kind of idea of crush syndrome was in the British Medical Journal after these patients were pulled from the rubble during German bombing in World War II. Next slide. The 2 doctors, Bywaters and Beale, again, it was published in 1941, but they described these 4 patients, and they all clinically had the same pictures where they were trapped for a long time. They had limb swelling, then they went into the kidney failure, they had decreased urinary output. And then because of their injuries, their amputations, they developed hyperkalemia, and then all of a sudden the patient died, which is pretty classic of crush syndrome. We tend to see these patients, they survive being trapped for a long period of time. We end up getting them extricated, and then shortly after extrication, they go into cardiac arrest. Next slide. So when we talk about the pathophysiology, I know no one really likes to hear about the nitty gritty muscle fibers and everything, but this does kind of set the background for it. Why does crush syndrome cause hyperkalemia, shock, and renal failure? When we talk about the sarcoplasmic reticulum, which is really just a net of tubules that overlies the muscle fibers. So when the actual crush injury occurs, we can see damage to this. And then what happens is that sodium, water, and calcium flood into the cells, and the cell swells, which leads to third spacing. So that's when we get the swelling of the extremities, the chest, or the belly. And then ultimately leads to almost like a hypovolemic shock, right? They become significantly volume down because of this third spacing. Next slide. We talk about the excess intracellular calcium, which signals the cell death, and then the cells die and then release all the badness inside. And that's what we call like a reperfusion injury, and it ends up just that's what ultimately kills these patients quickly. So EMS and rescue free the patient. You think everyone's high-fiving each other. We got them out, and then all of a sudden they decompensate, right? Because what about all those toxins that were crushed in the leg? Where do they go once you relieve that compressive force off that extremity or off that chest or off that belly? Then they're rushed back into the circulation and lead to the frustrations that we see later. Next slide. So we talk about the bad stuff, right? Myoglobin causes renal failure. We see free radicals that cause cellular damage. Histamine we see in other pathologies, right? We see it in anaphylactic shock. It causes profound vasodilation, which then leads to hypovolemic shock. We can see bronchospasm. The nucleic and organic acids ultimately decrease your cell pH, and we know that acidemic patients end up doing worse. And then ultimately, the big killer of crush syndrome is potassium. They become profoundly hyperkalemic, and then ultimately succumb to some kind of ventricular arrhythmia, whether it be VF or VT, from hyperkalemia. Next slide. We talked about this reperfusion injury, right? So once all the contents of these dead myocytes or dead cells, we release that compressive force, and then those are just flushed back into the system. We end up seeing patients succumb pretty quickly, and we found that with these patients that have been pretty well published, showed that up to 20% of trapped victims died quickly after being freed. This happened to that famous Amtrak patient outside Philadelphia years and years ago. But the most likely cause of death from these crush syndrome patients is arrhythmia from hyperkalemia, or ultimately shock from hypovolemia. And it's really, really tough because although we see the third spacing with fluids from these cellular injuries, and we see volume down, patients, we want to give these patients fluid. What makes it really, really challenging is that oftentimes these patients are also suffering from hemorrhagic shock, right? Because you think traditionally as a trauma, these patients have suffered some kind of polysystem trauma. Very rarely is it just an isolated injury. but we know that giving excess fluids in these hemorrhagic shock patients dilutes the coagulation cascade and leads to worse outcomes. So these are incredibly medically complex patients that require a balanced approach. And we talked about, when we go back to that patient that we saw trapped in the hopper, that's why we ended up giving 5 units of blood in addition to 3 liters of normal saline. If we would have just given them normal saline, we would have run into pitfalls from a hemorrhagic shock treatment perspective. And if we would have just given blood, we wouldn't have washed out some of these, the myoglobin, and prevented the renal failure from the crush syndrome. Next slide. So incredibly medically frustrating, complex patients. So again, what are the major problems with crush patients? We tend to see hypovolemia from that third spacing of fluid. We see hyperkalemia from this toxic release of substances. That is one of the feared complications that we typically see. And then we see ultimately renal failure. And depending on your scenario, we can see crush syndrome as early as 30 minutes, although it's not as common. Typically, they have to be trapped for about an hour before you start to see these constellation of symptoms. You can see it as low as 30 minutes. Under 30 minutes, it's likely not going to occur. But we tend to see the longer you're trapped, the more likely you are going to develop renal failure, just because of decreased urinary output, and they tend to not have appropriate treatment at the point of injury, whether that's just due to delay of extrication or delay of medical care. So these all must be kind of tackled all at once to consider that adequate treatment. Next slide. So some of the things to consider, right? So questions when you're thinking, who's at risk for crush syndrome? We talked about these. These are going to be your patients that are typically we see in a traumatic setting where, earthquakes, vehicle entrapments, you can see it in trench rescue, or you're going to see a lot in like industrial or machinery related incidents. Wartime, if any of you are in the service, you likely over the next few years are probably going to experience patients who have succumbed to this type of injury. Does everyone buried under rubble develop crush syndrome? And we'll talk about that, but no, not everyone. Just because you have a crush injury doesn't mean that you're automatically going to develop a crush syndrome. How long do you need to be crushed? We talked about that a little bit. It has to be at least 30 minutes. But we typically don't see it unless you're trapped for about an hour. How much of you needs to be crushed, right? And we'll talk about that in a second. Do victims of crush syndrome always have major orthopedic injuries? What are the most common presenting signs and symptoms, and how should we treat these patients? Next slide. All right, when we talk about causes of death, we talked about not only is there the immediate trauma from the patient, which is the number one killer, right? The number one killer of these types of patients are the traumatic injury itself, whether it's profound head injury or volume loss from hemorrhagic shock. That's the number one killer, traumatic asphyxia. Then the killer behind that is going to be hypovolemia and hyperkalemia. Next slide. So does the site of injury influence the development of crush syndrome? I'm going to say yes to a degree. We typically see it in lower extremities, right? And just anecdotally, we tend to see lower extremities trapped more often than upper extremities. But the overwhelming majority will be lower extremities. Truncal is even less common, but has a significantly higher mortality for a multitude of reasons, right? When we consider if you get trapped in your chest, you have some kind of compressive force that's probably limiting your respiratory drive. You have a number of major organs in there, your heart, your lungs, your aorta, that if you've had enough of a compressive force could do damage to those as well. So the mortality from a chest crush is significantly higher than others. And ironically, when you pull these larger case studies of earthquake victims, only about a third of them actually had fractures. So you don't have to have a major orthopedic fracture to be at risk for crush syndrome. You can develop it, and up to a third of patients actually, only a third of them had documented fractures. Next line. So we talk about clinical features, right? We talked about the three big ones. We have hypotension, we have renal failure. So the hypotension results from that massive third spacing, right? So we want to pound these patients with fluids. We tend to see renal failure, and that constellation of renal failure is secondary to rhabdomyolysis from the release of myoglobin, the potassium. And that's where we start to see the issues with the potassium, right? So the renal failure is usually acute, right? Unless you have someone who stood up from their dialysis machine and their dialysis machine crushed them for 8 hours. This is an acute kidney injury. So flooding them with fluids is really the first step, but it's that acute kidney injury that predisposes them to risk of hyperkalemia, because that is how we metabolize potassium and get rid of it. So they tend to have hyper K, and then we see the metabolic abnormalities, right? The hyperkalemia. We tend to see a lower calcium because it's all driven into the cells, and we see an elevated in lactic acid, and that's from muscle breakdown, and all the other acidotic metabolites that are released into the system. So these patients are incredibly acidotic, which makes it challenging. And just like agitated delirium, right? These patients are so acidotic that once they arrest, it's very difficult to get them back. It's an extremely high mortality. So the more aggressive we can get with treating these patients before they reach that point, the better the survival odds. But when you have patients who are that profoundly acidotic, it is very difficult to get them back once they arrest. And that's fairly true of all pathologies, whether that's diabetic ketoacidosis, or some other profound acidotic state. That's kind of the end stage of their acidemia, right? So you see pHs once they start getting into the 6, if you read an ABG or VBG, you're really competing against yourself, because it can be very, very challenging. Next slide. So when we talk about pre-hospital, right, how do we identify? Obviously, we can take someone's blood pressure and find that they're hypovolemic or their blood pressure is low. But how can we tell about hyperkalemia? Because I know for a fact none of us carry point of care labs unless you're maybe one of the helicopter services doing studies. But even at that, how can we as field providers know if someone's hyperkalemic or have an idea, right? We don't have point of care labs. We can do an EKG though, because we tend to see EKG patterns that relate to the degree of hyperkalemia. So next slide. If you talk about the EKG patterns that we typically see, like classically, you have your normal QRS complex, all the intervals are great, right? And then potassium's greater than 6, we'll start to see those T waves peak. At 7, we'll start to see the QRS widen. Your PR interval will start to get a little longer. Those T waves will become more peaked. And then once you're greater than 8 and 9, those where you start to see that sine wave pattern, you can get a junctional or a profound bradycardia. Oftentimes it can look like a 3rd-degree block. And then you develop some kind of ventricular arrhythmia and arrest. This is not steadfast, right? So I've seen patients with potassiums of 7 and have a normal EKG, but this is kind of like a general guideline. So if you see these, you may consider hyperkalemia, but just because you don't see these doesn't mean that you aren't at risk for hyperkalemia. Now I'm going to tell you, if you have a potassium of greater than 8, you're going to have EKG changes to some degree, right? Next slide. So these are just some examples, right? Those are those tall peak T waves. Those are evidence of hyperkalemia. You can start to see some widening of the QRS in this. Next slide. And then this is kind of like you're starting to reach the end. This is your potassium starting to reach levels greater than 8 at this point. PR is severely prolonged, almost absent. Your QRS is extremely wide. This is kind of the end stage or that sinal pattern. Next slide. So how do we treat this, right? The very first thing is you have to have a high degree of suspicion for this condition and begin treatment before you extricate the patient, because this is one of those things that if you wait to again find the patient and arrest, you're already behind the 8 ball. This is why I make a strong case for medically directed rescue, particularly for these types of incidents, right? This is where you need the medic at the point of injury. This is not where we can stand at the ambulance and wait for the fire department to extricate and bring them to us. This is, you have to throw on the helmet, you have to get your turnout gear on, you have to go in, and you have to start lines, give fluids, and start treating at the point of injury. And there's very specific things that we need to do right before we extricate the patient to help kind of prevent the complications that we see with that reperfusion injury. So we release the patient, and all that badness goes back into the system. So we, again, what are the types of patients that we should consider? We need to consider crush syndrome in anyone that's greater than 30 minutes. That's in the state protocol. Again, we typically don't see it until about an hour, but you should start to think about it at 30 minutes, right? If you have someone trapped and you're reaching that 30-minute mark, you should just start to think like, is this something I need to be thinking about? And do I need to take action, right? And then they obviously have to have some kind of crushing or compressive force. And this is when we talk about what needs to be crushed, right? You are not going to get compartment syndrome if your fingers are trapped under something. You're not going to get it if it's your hand. But if it's your entire right upper extremity, you have a chance. If it's your left upper extremity or your lower extremity, you have a chance. But it's not going to be, if it's just a hand or a foot, it's very unlikely to cause crush syndrome with just those small distal aspects. Next slide. What are our treatment options? What do we carry in the field that we can give depending on your level of certification, specialty teams? But typically we want to be really, really aggressive with fluid, right? And what type of fluid do we want? Ultimately, all the fluid kind of sucks, but if we had to choose one of them, normal saline is probably the one that we have access to, is the best one. The pH of normal saline is pretty acidotic, but it doesn't carry as much potassium as lactated ringers. Now, that's a theoretical risk. When we talk about lactated ringers, not only does it have lactate and it has potassium in it, again, it's theoretical, but if we're fearing, a profound metabolic acidosis from elevated lactate, and we're fearing hyperkalemia, we don't want anything that may water that picture. So try to stick to normal saline as best as possible. When we talk about sodium bicarbonate, we really want to be aggressive, and these patients are going to suck up a ton of sodium bicarb. So if you have a potential crush patient and you only have 2 amps of bicarb in your drug box, you better be calling other medic units to get some additional bicarb, because you're going to go through this incredibly fast. When do we start to give bicarb? Well, you really want to start to consider bicarb once the QRS starts to widen. If you truly have a crush patient that you are going to treat for crush regardless prior to extrication, it doesn't matter what the QRS is. You're given 1 to 2 amps of bicarb literally right before you pull them out. It's like, give the bicarb and 30 seconds later you're pulling them out. That is kind of the timing of that. Otherwise, once you extricate the patient, or even if the patient is still trapped and you're starting to see a prolonged QRS, so that QRS complex is greater than 120 milliseconds, you want to give an amp of bicarb. Albuterol. So this is kind of one of the classic teachings of hyperkalemia. Does it actually do anything? The evidence doesn't really support it as much, because you need high volumes of albuterol. You need traditionally at least 10 milligrams of albuterol to affect any change. But again, these are going to be patients that are probably trapped in precarious positions and terrible atmospheres. So don't forget your humidified oxygen. Really keep their oral pharynx moist, and then just start dumping albuterol into them. We obviously don't have glucose and insulin and the other things like Kxalate, Lasix, mannitol, and dialysis. We can't do those in the field, but that's typically the more extremes for hyperkalemic treatment. And then calcium. You always want to give calcium as well. And the reason you want to give calcium, not that it really affects the potassium as much, but the primary reason we're giving the calcium is to stabilize the cardiac membrane, right? Because we don't want those heart cells becoming more excitable than they have to. And that's primarily because if they're already at risk for hyperkalemia, then or ventricular arrhythmia, we don't want to predispose that with any kind of excitable heart cells. So we want to give the calcium chloride. The key is you don't want to give them through the same line, right? Don't give sodium bicarb and calcium chloride through the same line, because you can precipitate salt formation, right? And then you'll just ruin your line. Next slide. Whoever said I'm going to try it anyway, just don't put my name on the chart. So again, this is the kind of the real big thing is you want to take the care to the patient. You know, if this patient is a potential crush syndrome, you really need to be aggressive and go in and provide care at the point of injury. This is not someone that you can wait to be taken out. You want to make sure that you establish good IV access. Start fluid resuscitation. These patients can often be 3-4 liters down, so don't be afraid to give repeat boluses. Right? What's the worst that happens? You know, if they start to flood their lungs, then you intubate them. I mean, there's you can't live. I'm under the philosophy. You know, we sometimes have to sacrifice one thing to be able to support others, right? So you can't live with a blood pressure of 60. So if we have to sacrifice your lungs and ultimately intubate you down the road, that's a price that I would be willing to take, because you know you are going to die from profound hypotension much sooner than you are from delayed airway complication. You know, pre-release alkalization, we talked about that. We talked about giving the 1 to 2 amps of bicarb immediately before extricating these patients, and then be prepared for the complications, right? So whenever these patients are moved, I would be ready to continue to pound these patients with fluids, give them more bicarb, treat their hyperkalemia. And how do we identify that? Is we have to have the patient on continuous monitor. So, you know, when we talk about taking care of the patient, right, this is kind of changing your mentality, because when we talk about vehicle accidents, we typically don't want to provide aggressive care for most entrapments, just because a lot of our medical equipment and treatment option actually delays extrication. But these are for the, you know, the patients that have been identified as they're going to be stuck for a while, they're at risk for this. We need to go in and take care of them. Next slide. So in the interest of time, I know I'm running short. These last remaining slides are really just a look at the Pennsylvania protocol. There is a specific protocol for crush syndrome. If you haven't reviewed it in a while, just take a look at it. It's actually one of Pennsylvania's better protocols. So take a look at it. It really just kind of reinforces everything that we've talked about. Make sure you have good IV access, whether that's IVIO, start fluid resuscitation, consider bicarb, calcium. Don't forget pain management. Ketamine's great for these patients. You know, fentanyl, nitrous oxide, as long as they don't have any chest wall injury, whatever you have, be aggressive with your pain management. Be aggressive with your fluids, your cardiac monitor, and your bicarb, your calcium, and albuterol. And these are very complex medical traumatic patients that suffer from multiple modalities. You may have someone who has a crush syndrome. They have a pneumothorax. They're bleeding out from a wound, so they're in hemorrhagic shock. So again, these patients, you will be sweating taking care of these patients by the time you're done. Next slide. Yeah, we're just going to burn through these real quick. This is, you know, just the state protocol. You can actually just burn through the state protocol slides. Oh, back up. Yeah. All right. Take home points. Have a high suspicion for crush syndrome. You'll never find it if you're not looking for it. These patients, again, you can start to consider it at 30 minutes, but we typically don't see the constellation of symptoms unless they're trapped for about an hour. These patients really look well until they're extricated, and then they suddenly crump. So again, be prepared for those constellation of symptoms. These patients will often become hypovolemic very quickly or hypotensive very quickly. They'll start to display evidence of hyperkalemia and then arrest very, very quickly. Treat early So get in there as soon as possible, start your lines, give them fluids, give them pain control, consider bicarb, calcium, treatment of hyper K. That's next slide. All right, that is it. Let me check the chat. Any particular questions? Again, you have my email. Feel free to email me if you have any questions. I apologize for the beginning and the kind of the issues with getting this lecture started. But if you have any questions about this lecture or anything else, feel free to email me. I think there's one question about Lasix. So it for routine use, you know, in terms of carrying Lasix, it's probably, if you're looking at the cost effectiveness, it's probably not up there. Now Lasix is fairly cheap, but it might be something to be considered for like your technical rescue team medical bag, right? Or but for carrying Lasix primarily for anticipation of crush syndrome, you're probably not going to see, you know, a good cost-effective strategy on that, because you might go a whole year without seeing someone with crush syndrome. But maybe for your like technical rescue teams, your medical assets. With the use of bicarb, how much is typically needed in this situation? It really depends on how long the patient's trapped and the kind of the circumstances. But for someone considering crush, you're probably talking 3 to 4 amps at a minimum. So I would be prepared to start pulling bicarb from places that you don't know where to find it.
Any other questions for Dr. Mulcahy before we go to the next presentation? Okay, Dr. Mulcahy, thank you so much for your time. We really appreciate it.
All right. Thanks again, guys, for having me.
Take care.